A 35-year-old female is intubated in the ICU following a severe drug overdose. She develops acute hypoxia and high peak airway pressure alarms on the ventilator. I am showing you her portable chest radiograph. Describe the findings.
The chest radiograph demonstrates diffuse, bilateral, relatively symmetric airspace opacifications with prominent air bronchograms throughout both lungs. The heart size is within normal limits. In addition, there is a prominent vertical lucency outlining the left cardiac and mediastinal border, representing an anteromedial left pneumothorax. Given the history of intubation and ventilation, the diffuse opacities are consistent with acute respiratory distress syndrome, now complicated by a left-sided barotrauma-induced pneumothorax.
Define the clinical and radiological criteria for acute respiratory distress syndrome, and name 4 common direct or indirect etiologies.
ARDS is characterized by the acute onset of severe respiratory failure, profound hypoxemia with a ratio of arterial oxygen tension to inspired oxygen fraction of 300 or less on positive pressure, bilateral lung infiltrates on imaging, and the exclusion of cardiogenic pulmonary edema. Common causes include sepsis, severe pneumonia, gastric aspiration, trauma, multiple transfusions, and drug overdose.
Why did this patient develop a pneumothorax in this specific location? What is the risk if it remains untreated, and how should it be managed?
The patient has ARDS, which causes severely reduced lung compliance. High-pressure mechanical ventilation leads to alveolar rupture and barotrauma, with air tracking into the anteromedial pleural space, which is the highest point in a supine patient. If untreated, positive pressure ventilation will rapidly convert this into a life-threatening tension pneumothorax. Therefore, immediate chest tube thoracostomy is required. I would notify the clinical team immediately and recommend urgent tube placement.